I'm today talking to you all about everything you wanted to know about AI, but you were afraid to ask. I am an assistant professor in the All India Institute of Medical Sciences. And at the very outset, I'd like to thank the organizers for giving me this opportunity. The presentation I'm presenting was originally presented by Professor Regina Barzile and was entitled What AI Can and Can't Do for Healthcare. And I hope to be able to capture the essence of her presentation as I go forward. Talking about AI versus usual clinical practice. Usually, clinical decisions are based on research which was conducted on a very small fraction of patient data. For instance, it was actually seen in a study that only about 3% of patients actually participate in clinical studies, which are the basis for us to decide many treatment options that we use in the current day, which is where AI comes in, because it actually gives you the ability to analyze much larger fractions of patient data. So we're hoping that the kind of conclusions we can derive when we do use AI in our clinical practice can be based on a much larger percentage of patients. So one of the most common forms of AI that we use, AI is a very broad term, but what we use commonly when we talk about most of the tasks that we use in clinical practice is called supervised machine learning. So what is supervised machine learning? Supervised means that you basically teach the system what you want to what you wanted to predict. For instance, if we were to take some examples from our real world, when we log into Netflix for the first time, when you create a user account and log into Netflix, Netflix asks you to choose 3 movies that you like the best. This is an example of how you're guiding the Netflix algorithm by telling it what your choices are. So the ground truth here is your choice of movies. Similarly, when you go to Google Photos, it would first ask you to pick out and name the people. It would pick out some faces and say, what do you call this person? So this is you guiding Google Photos and telling Google Photos that this is the person. So the ground truth you are providing is the name of the person that you would like Google Photos to identify for you. Similarly, if you were to take this to mammograms, the supervision comes from either drawing a box around the cancer, if it's a detection task, if what you want to do is detect the cancer, or if you simply want to classify an image as being cancerous or non-cancerous, you would guide the machine learning tool by really telling it whether the image has cancer or does not have cancer. So this kind of task where you are teaching the algorithm during the training phase what you wanted to predict is called a supervised machine learning task. So going further in the same example that we were talking about in terms of predicting preferences from data, this is one of the examples that Professor Regile had given in her talk. When you actually choose the movies that you like, let's say that a movie you don't like is annotated by a -1, and a movie that you do like is given a value of +1. Your task is basically now to go ahead and, given a new movie, predict whether or not you are likely to like this movie. So the task of the machine learning is to learn some features in this particular list that you have provided it, which makes this movie likable to you, as an example. So what are these features it could learn, and how are they provided? So these features could be explicitly provided. For example, if the algorithm was to ask you a question about, say, the genre of the movie, then you could come to a conclusion that the first few movies were action and thrillers, and say a comedy was try to piece together this information that you've given it, and probably think of something like, if it's an action plus a comedy, that's something that you seem to like. So that's an example where a feature is explicitly provided. However, if you have a very large number of training examples, like we often do in today's day, if you have a deep learning algorithm, which is what we commonly use in today's day, a lot of these features can be automatically picked by the network. When you put together these features and you construct a vector, this mathematically is called a feature vector. So this is how a feature vector is formed from the information that you provide the network. The next task is simply to provide a decision boundary. So what is the decision boundary? If you were to represent each movie in space mathematically, geometrically, then let's say that each movie actually occupies one particular point in this particular graph. Your task as a machine learning expert would be to find this boundary which separates the movies which are liked versus the movies which are not liked, so that when you are able to allocate one particular point in space to this new movie that has come in, you would know whether it falls on this side of the line, which is the liked side of the line, or the unliked side of the line. So finding this particular line in space is a mathematical representation of the model that you're trying to train. This, of course, is an oversimplification of the task. Often real life decisions are not based on one or two factors. So it's not a two-dimensional figure that you're going to get over here. It's a multi-dimensional figure. And even your decision boundary is likely to be a much more complex function, which may look something like this. And if over here you wanted to separate the red dots from the blue dots, you might want to find an extremely complex function that does so in the best interest to get the maximum sort of benefit in terms of the separation. One very common question that is often asked while starting a machine learning task is how much data do we need to train such a task? So there is no single answer to this question. It really depends on a lot of factors, one of which could be the complexity of the task that you're looking at, another of which is the complexity of the model you're trying to train. But in general, when you keep increasing the data, the accuracy of the system is likely to get better. This is not going to be a linear sort of relationship where as you keep increasing the data, the amount of increase may not be proportionate to the increase in data. For instance, when you go from say 10 images to 100 images, there's a huge jump in accuracy. However, when you go from 500 to 1000 images, there's only a minimal change in the accuracy. And this change may not be really worth the effort that you put in to collect the data. This, of course, is just for representation purposes, and we're not really talking about 500 or 1000 training examples. This is a graph which is plotted out of one particular example for a task. So if you were to actually design a supervised machine learning task, what would be the steps that are important to go forward? Firstly, you convince yourself that there is actually a pattern in data. Because if you give data without a specific pattern in it, the task is really not going to be able to find a mathematical function to represent that. The second task to do would be to decide what features to use. Now, this data abstraction feature is more important when it comes to some of the older techniques. When you come to deep learning, like we had discussed in the previous few slides, you're not actually picking out features. That's something that the network learns from the data that you give. But in some of the older machine learning tasks, you do explicitly tell the system what features to pick out. So how many features should you pick out? Should you pick out a lot of features, or should you pick out just a few features? As a general thumb rule, it's a good idea to pick out as many features as possible, even though some may be irrelevant. This is because the modern day tools that we use for machine learning are extremely powerful and are capable of handling even the irrelevant features. However, if you miss out on picking out some relevant features, you may not be able to compensate at a later point. To give you an example for better clarity, let's say you're actually performing a task where you want to pick out certain features on a mammogram which may help you decide whether or not it is a malignancy. You might be thinking about picking out, say, the margins, the shape, the density, etc. But if you were to skip one of these and then provide it to the machine learning task, which means that if the machine learning task simply doesn't know whether there was architectural distortion or not, as an example, then it will not be able to utilize this for formation of the model, which makes you make a much less accurate model than you would have ended up with otherwise. The next task is to collect annotated data. Now, this is perhaps the most boring and the cumbersome step of the process. It is extremely cumbersome to sit down and carefully annotate data, but it's also one of the most important steps because this essentially determines how robust your network is going to be. And the last is to evaluate your model. The importance of this step in medicine cannot be overemphasized, given that in medicine, the scope for error, of course, is much lesser than there is in any other field, perhaps. So, evaluating your model, looking for possible biases that may have come out of choosing your training data, choosing an appropriate test set which is large enough, which has enough variety, is all a very important step before you can actually go ahead and put it into your clinical practice. So we kept speaking about deep neural networks. So what are deep neural networks? We commonly use these deep neural networks, which derive their inspiration from the biological neuron. So just the way you have sensory organs which pick up your sensations and then pass them on to synapses, which will then pass them to the next layer of neurons. Loosely, this is where deep neural networks get their inspiration from. There would be an input layer. So these are the inputs that you're giving, the images or the other variables that you want the network to take as input. Then there are many, many layers of mathematical functions. At the moment, it would be sufficient to just call it some mathematical functions that are going on over here. And then finally, an output layer, which is your final prediction layer. These are essentially called hidden layers. And some layers will get activated. It's called activations, just the way some neurons and some synapses get activated and then pass on the information to the next layer. This hidden layer is very large in case of a deep neural network, which is why they call it deep. That's the meaning of the term deep. And this depth gives it enough complexity to be able to handle very large amounts and very large volumes of data. So why has deep learning really come to the fore in today's day? Deep learning and machine learning as a concept have been there around for decades together. However, today we stand at a position where we have lots and lots of digital data, which is very easy to transfer. In addition, we also have a lot of computational resources. For example, graphic processing units, which are the kind of systems we use to analyze these images particularly. This is particularly important when you're using images for your task. And all this gives us capability to handle very large models, which become easy to train. And they literally fit like flexible Lego pieces. And you can take and borrow from these networks which have been trained on natural images and then simply use them for your medical images in today's day. Computer vision is actually fairly similar to what humans do. Of course, it's not half as complex as what humans do, but in general, just the way human vision develops, where you sort of learn to identify simple things first. You learn simple parts and you put together these parts to understand what objects are made up of. Similarly, in computer vision also, it's been seen that the earlier layers actually learn very simple features like edges in this case. This is a face detection algorithm. The next few layers would learn slightly more complex things. For example, if you were to visualize what the mid layers of this neural network is learning, you would start seeing some noses and some eyes, and all these are pieced together when it comes to the last few layers to complex facial structures, which is what the network is trained to learn. And this is the hierarchy with which the algorithm actually learns to identify things. So the tasks that machine learning can do is essentially divided into tasks which can be automated, the tasks where humans are actually experts and can be automated to do. Then there are the tasks which humans really cannot do. So these are the superhuman capabilities that we are trying to exploit of machine learning. And the last, which is an emerging field, which is not something which has been extremely well explored, is gaining fresh insights and trying to understand certain disease processes. And coming to the first task, which is tasks which humans can do, machine learning can actually be extremely effective at doing such tasks. And let's look at an example of why that happens. The author, Professor Regula, actually spoke about a study which was studying atypia progression. And before the AI era, these are two articles from very reputed journals, one from the New England Journal of Medicine, the other from JAMA. And the number of cases they saw were about 336 in the first case and 674 in the second case. So like you can see, even though atypia is as common as it is, the number of cases they were able to churn out and study was a fairly small number. With AI, however, AI gives us the ability to really analyze a much larger subset of cases. It's easy to construct a data set with about 6,000 cases, because now you don't have to manually go over each report to find the atypia. And that gives you the ability to look through your electronic medical records and find these in a much more robust way. However, finding this is not going to be trivial, because not everybody would write atypia in the same way. This was one particular example she gave, where she's talking about how somebody would call it a severe atypical ductal hyperplasia, going on to someone calling it a borderline DCIS. So finding these terms is non-trivial. It would need several queries for you to give it in, and a particular kind of machine learning that can do this, deep learning in fact, is called natural language processing, which allows you to understand language rather than simply just finding phrases which it can match. And this has really expanded our ability to go over medical records in order to come to sound conclusions. One particular area of caution before we move on to the next use case is that tasks cannot typically be completely automated with the use of AI. It's a good idea to not do so, because the weaknesses of AI is very different from the weaknesses of human beings. And sometimes things which are very obvious to humans can be missed by AI. Similarly, human interpretation actually brings in a certain value which cannot be replaced by AI, which brings us to the very common epithet that radiologists who use AI are likely to replace radiologists who do not use AI. And machine learning tasks actually bring in a very narrow intelligence, which is specific to one particular task. And looking at a replacement model is likely to not take your project very further, because it's unlikely that something like that will be possible in the near future with the current abilities and capabilities of artificial intelligence. Coming to tasks which actually extend human capability, um, deep learning is capable of finding certain features which may not really be truly visible to the human eye. For instance, if you were to look at progression of certain lesions to become cancer, this is one area where humans actually don't do very well. This is an example from the author's own study, where she talks about a particular lesion in the breast, where the task was to predict a 3-year progression of lesions into cancer. And they were able to show that in their data set, AI actually did much better than humans when an outcome of that kind was being fed. So AI actually became a much better predictor of future, which is something that humans cannot really do quite as well. And in addition to showing it on their own test set, they showed it on data sets which were derived from across the globe. And as you can see, they reported extremely high accuracies and comparable accuracies to the original test set across the globe, showing that this was actually fairly generalizable to the general population. Another area where AI has been shown to do excellently well is predicting the risk of development of cancer. So traditionally, when we as human beings do this, we use factors like age, family history, prior breast procedure, and at the most, if we're using images, say in mammography, we can use something like a breast density. But actually, dense breasts actually constitute up to 42% of mammograms that you read. So this is not a very useful way of stratifying the risk. So this particular study actually looked into that and developed AI models which are capable of predicting the future risk of developing cancer. And the authors of the study were actually able to use it in the real world during COVID times, where by predicting the risk of development of cancer, they were able to call back patients who were specifically at high risk to continue with their annual screening, even though screening as such was not being offered during the COVID situation. So this is one example of where AI can actually bring in true value in the real world and change the clinical practice, the way we look at it. What do you really train AI to do could be something which is explicitly measurable. For instance, all of these examples where predicting cancer was the outcome, or it could be something that we are not capable of looking at as human beings. For instance, if we were to actually just try to predict the histology from a mammogram image, that could simply be an outcome that you ask AI to predict. So your model is going to be trained the way you kind of give it the outcomes to train it with. Two important questions that the world of artificial intelligence is trying to answer is, how do we ensure that these models generalize, and how do we interpret those models? So coming to generalization of models, what generalization typically means is you may have shown the accuracy on a particular test set, but what are the chances that this accuracy will actually carry forward when you go into a fresh situation, a new test set, which may come from a different distribution, different patient distribution, a different region of the world, a different race of human beings. So often, or even different equipment which are used to acquire these images. So this problem of generalization is something that the AI community as such is struggling with, and several checklists have come out in the recent past. CLAIM is something that as medicos we may all be aware of, and similarly the MICAI generalizability checklist, reproducibility checklist is another one such checklist to ensure that your model is built in such a way that it is likely to generalize. Another important hurdle is interpretability of these models. Often you may have heard of people referring to these AI networks as being a black box. And the reason we refer to them as black boxes is because it's very hard to understand what the AI algorithm is trying to decipher. While in case of humans, you can simply go and ask them why they made a certain decision. AI possibly cannot tell you why it made a decision that it did. So interpreting these models to understand what they're looking at when they're making a decision is extremely important. Some examples of where this can go wrong and why this is important. One of the examples that Professor Regli mentioned is this particular example where the network was trained to predict or to guide the treatment procedure based on information it gathered from electronic medical records. However, when you look at the electronic medical records, not all patients are fortunate enough to get the same kind of treatment. Because of some inequalities, certain races in the United States, where this article actually comes from, did not receive treatment simply because of financial difficulties. And the algorithm ended up being trained to not provide or not predict a certain kind of treatment for these races, simply because what it read from the electronic medical records was something completely different. It read that a certain race was actually getting suboptimal treatment, and it ended up guiding medical treatment in the same way as it had been trained to do. Another example would be that clinicians typically have different thresholds for calling it a cancer. For instance, if you were to try to predict, again, I'm taking the mammogram example again, cancer from mammography, and you were to use the BIRAT score, there would be a high variability in how different clinicians actually give a BIRAT score. And therefore, if you use a non-standard, non-gold standard, non-histological gold standard for training these algorithms, there would be a lot of noise in the way these algorithms are actually trained. And if we don't take care of such biases, AI could actually end up worsening healthcare disparities across the world. This is another example of interpretability and the reason why generalizability and interpretability is quite that important. So this was an algorithm which was trained to predict or detect human beings. Now, if the algorithm was fairly confident in calling this particular thing a monkey or a non-human being when the guitar was not there. But the minute you put in a guitar on top of this image, the algorithm very confidently predicts this to be a human being. The reason for that being that every time in the training data, the algorithm saw a guitar, there was always a human being holding it. So this kind of represents the kind of biases that can be introduced into the system. And one example, if I was to give from our own practice, at one point in time when we were training algorithms to detect pneumonia, the training examples had a lot of ICDs in patients who did have pneumonias. So the algorithm ended up taking ICDs as a surrogate marker for presence of pneumonia. And this is something that we ended up realizing when we gave a different test set where the patients did not have ICDs. So this kind of dangerously, explicitly exposes the kind of biases that you could introduce very inadvertently. And these biases can be very difficult to pick up because of the number of factors that are there in medical science in making a particular decision. So it's very important to ensure that the algorithm actually generalizes to different kinds of patient populations before you can actually put it into clinical practice. One little caveat when it comes to interpretability of cancer is that sometimes cancer may not really be. Although you can sort of derive heat maps, you can say where your network is focusing while making a particular decision. When it comes to tasks which have a suprahuman capability, it may not really be possible to really tell why the network actually made this decision. And that makes interpretability very complex because for things that we don't know, it's very difficult to verify whether the network is actually doing the right thing or not, and verify whether what it's doing is for the right reasons or not. And with that, I'd like to thank you all for your attention. In the interest of time, I'd just like to skip this slide and hand it over back to Dr. Jyoti.